Thank you, Olga. That was a very nice introduction. And a lot of the points that you made will be repeated a little bit. So let's start with a case. This is a 71-year-old, so not a super elderly patient, but right-hand dominant with no comorbidities. She still works and enjoys gardening and a low-energy fall. So you can see that she's got a fairly distal and comminuted distal humeral fracture. And these are her CT scans. And when you look at these when I look at these CT scans, what I'm seeing is that there are multiple fragments in multiple planes, and the fragments themselves are very shallow. So lots of shallow porotic fragments with impaction of the articular surface. So at this point we have options. So non-surgical treatment we should always consider, but in an active person that's not the case. Fixation, of course, and then hemiarthroplasty or total elbow. And for me, in this sort of case, it's reasonable to consider an arthroplasty. But the question is, do we do a total elbow or a hemiarthroplasty? And I'm going to talk a bit about hemiarthroplasty. You have to remember that whatever happens, internal fixation is the gold standard, and it remains the gold standard whenever possible, even in elderly patients, and that's really to do with the bone quality. When you look at the evidence to talk about elbow replacement or total elbow versus fixation, really two papers are commonly quoted. One by Frankel and one by McKee, and they've both shown superior outcomes with total elbow replacements. But you should just pause and think about these papers a bit more. So here's the paper by McKee, and then actually a follow-up paper with their results, where they showed preserved improvement with total elbow compared to fixation. But I'll put it to you, remember these papers were published in the early 2000s, and they were using reconstruction plates with principles and implants that we wouldn't use now. And if I showed you that x-ray, which is taken from their paper, we wouldn't be happy with the fixation. We would all find ways to criticize the technique. So some of the data and their results may actually be outdated. We may be better now at fixing fractures than we were. If you look at the results of elbow replacement, total elbow, as Olga said, as soon as you get into mid and long-term results, the rate of complications start going up. And it's not just the rate of complications, but the complications that occur can be extremely hard to manage. Look at this case. This is a 66-year-old who underwent a primary total elbow for fracture. With loose stems, bone loss, possibly infected triceps failure. It's a complete disaster and a life-changing problem, probably because of incorrect decision-making in what operation was performed. So hemiarthroplasty is the sort of new kid on the block, but it's not that new anymore. It's been around for some time, and it has the potential advantages of an arthroplasty, but it may remove the ulnar and bearing related complications. So it's an unlinked prosthesis, so it relies on ligament stability. But it raises some new questions. So what are the actual indications for a hemiarthroplasty? Are the results comparable to total elbow or even fixation? And will it last as long? And it also introduces a totally new spectrum of complications, so wear of the native joint and instability are the two ones you'd worry about. We did a systematic review some time back now, and that basically showed that the rate of complications was around 28%, but in fact, the main reason for complications in the systematic review was metalwork prominence, and that's because many of the early hemiarthroplasties were done through an olecranon osteotomy, so we don't do that anymore, so those complications will reduce. In the UK, we have a national joint registry, so all arthroplasties across the body, apart from hands, and have to be put into the registry. It's a legal requirement, and then they're tracked. So we're building up data, and because of the number of cases we do, I think it actually has the largest number of elbow replacements in the world in one registry. If you look at the rate of total elbow, there's still not that many done. So there's only about 400 total elbows done. And if you look at hemiarthroplasty, this is for trauma, it's going up. So it went up quite significantly a few years ago, and it stayed at that level. Now, if you also look at these are results from our registry, the revision rate after hemiarthroplasty versus total elbow, there's some indication that the early revision rate is higher with hemiarthroplasty. It's difficult to draw conclusions because there's far fewer patients in the registry at the moment who have had hemis than totals, but that's something to be aware of, and that could be because of instability, which isn't an issue in total elbow. The total elbow complications come later. So what are the main fracture indications for hemiarthroplasty? Really, for me, it's a very distal fracture. When the columns are fractured, Olga showed a couple of examples of fixation, and if you look in detail at those fractures, the articular surface is good quality. The columns are fractured. In some of these examples, especially the coronal shear, they have extremely comminuted bone with intact columns. That's the ideal situation for an arthroplasty. Contraindications, so obviously if you can fix the fracture, if there's pre-existing arthritis, then you don't do a hemiarthroplasty, you would do a total elbow replacement. And if there is associated coronoid fracture, which might lead to instability. And also revision of failed fixation isn't a great indication for hemiarthroplasty because the anatomy of the ligaments and soft tissues is distorted, and we need stability from the soft tissues for a hemiarthroplasty. So I mentioned this approach earlier. If you can, look it up and try it in your lab session tomorrow for a distal humeral exposure. So this is a sort of approach it's called the paraolecranon. It keeps the triceps tendon on the ulna, and it gives us a very good view of the articular surface. So I use this approach for internal fixation, hemiarthroplasty, and total elbow replacement. So it's a really good approach if you can learn it and read about it. So one of the key factors is soft tissue stability. So this is how we repair the ligaments and the epicondyles. They actually get repaired through the implant, which has a cannulation, and then around the implant. And I'm not going to show you all the videos, but if you go onto ViewMedi, you can see in full detail how we repair those ligaments. But the message is it's really important to repair the ligaments and the epicondyles. Sometimes we have condyle fractures that are much bigger, and again, in a hemiarthroplasty, you have to reconstruct them. So you may use plates, or I quite like using buried threaded K-wires. But we often see epicondyle non-unions. So here in this case, the patient's got non-union of the epicondyles because we don't really get compression through those little bits of bone to the shaft. But what we do notice is that they don't migrate. So the ligaments end up scarring in the right place, we think. Now this is a complication of a hemiarthroplasty that was sent to me. So you can see a 58-year-old, so already a young patient, working, who has a dislocated joint. Already had a revision by the surgeon with soft tissue repair, but repeat dislocation. And the reason for this is that you have to pay attention to the rotation of the components. So if you look at this case, the patient's had his hemiarthroplasty mal-rotated, and that will put uneven stresses on the ligaments. When you're doing any total elbow replacement, even a total elbow or a hemiarthroplasty, rotation is important. And the axis of rotation, just like in knee replacement, goes through the epicondylar axis. And we can, when the condyles are fractured, we can use the posterior humeral surface as a gauge for the correct rotation. You have to have the implant internally rotated slightly compared to that axis. Otherwise, you'll put stress on the lateral ligament and it will dislocate. So here's another example, just an 89-year-old lady, that fracture I showed you with 5-year outcome of hemiarthroplasty, doing really well. So post-op, we start immediate range of motion because we've fixed it's stable. We start supine and overhead exercises to use gravity, and we avoid loading through the arm or various forces. We don't use HO, and it's probably safe to say there's we can be more relaxed about loading through a hemiarthroplasty than a total elbow, which is another reason why it's probably better suited to trauma. This has been our experience so far. So we've got 42 patients. Mean age is 73, but one very young patient. And really no revisions, no instabilities. And then, as I said, you will get the odd ulnar nerve problem. So hemiarthroplasty, the indication is when you might consider a total elbow. It's probably better suited to trauma, and the early evidence is of good results. But in truth, we don't know which is better. And in Sweden, they've just completed a randomized control trial, which they're going to publish the data on. And in the UK, probably next year, we're going to start a randomized control trial on that subject. Thank you.